Okay, so infective endocarditis, or IE, it might sound rare, but when it hits, it really packs a punch, doesn't it?
It absolutely does. We're talking a potentially life-threatening infection deep inside the heart, the lining, the valves.
Right, and maybe you don't see it every single day on the wards, but getting the key details straight is, well, it's vital,
hmm
especially for exams like the MSRA. Yeah,
Exactly. Think of this as us pulling out the really high-yield stuff from those revision notes, the need-to-know info.
because missing it, that can have huge consequences. So the goal here is pretty simple. Extract the core knowledge, make it stick for recall, and understand why it's so important clinically.
Yeah, misdiagnosis is definitely a risk. So let's dive in.
Okay, so i.e., it's an infection, right? Usually bacterial, sometimes fungal. And it affects the endocardium, that inner lining of the heart chambers, and crucially, the valves.
Mm-hmm. And the main players, the bacteria you see most often. Top of the list is Staphylococcus aureus,
Yeah.
one.
And then,
Then you've got others like Streptococcus viridans, Staphylococcus epidermidis, and Streptococcus bovis. Those are the common ones.
got it. Staph aureus, strep viridans, staph epi, strep bovis. And what about that HAC group?
Ah, yes, A-chic. It's an acronym: Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, Kingella. They're less common, definitely,
Okay.
but they cause a sort of slower, more indolent kind of endocarditis. And they can be tricky to grow in the lab.
Ah, so that links into the culture negative cases sometime.
Exactly. That's one reason for culture negative IE. And remembering ASHIC, just saying the name, AC, can kind of help it stick.
ACE, E-sheet. Right,
Eh.
so who actually gets IE? Is there a typical patient?
Well, it's quite varied, actually. You can see it in people who had totally normal heart valves before.
Really? Okay.
Yeah, but also, more classically, people with pre-existing valve problems like rheumatic heart disease or those with prosthetic valves.
Right, prosthetics make sense.
Definitely. Congenital heart defects too. And the really classic association is intravenous drug users. They often get the tricuspid valve involved.
That right-sided endocarditis.
Precisely. And sometimes less obvious things pop up, like recent body piercings even.
Huh. Okay.
Yeah.
So let's loop back to those common causes and link them a bit more. Staph aureus.
Yeah, Staph aureus often think acute, severe infection. And like we said, IV drug use, high mortality with that one,
What?
unfortunately.
And strep viridans.
That's the one strongly linked to dental procedures or poor dental hygiene. Think mouth bacteria getting into the bloodstream.
Right, the dental link. What about coag-negative staph? Like staph epi.
Coagulus negative staph, often associated with prosthetic valves or maybe indwelling lines, catheters, that sort of thing, usually a bit more subacute.
Gotcha. And you mentioned strep bovis earlier.
Yes, and this is a really crucial one for exams. If you see Streptococcus bovis bacteremia, or IE, caused by it, you have to think about underlying colorectal cancer.
Wow. Okay, so that IE diagnosis triggers the cancer workup.
It absolutely should prompt a thorough investigation. Yeah, very important link.
And are there non-infective causes too? Things that look like IE but aren't bugs?
Yes, definitely. Good point. Conditions like SLE, systemic lupus erythematosus, can cause something called Liebman-Sachs endocarditis.
Oh, okay.
And certain malignancies can lead to what's called murantic endocarditis, which is basically sterile vegetation, so not actually an infection.
Right. So what happens when you suspect IE? You do the blood cultures and
Yeah,
nothing grows. Culture negative.
Yeah, that makes diagnosis tougher, obviously. The most common reason by far is that the patient has already had some antibiotics before the cultures were taken.
Oh, okay. Kills the bugs in the blood sample.
Exactly. But sometimes it's because the organism itself is just hard to grow using standard methods,
Like the HAC group you mentioned.
like HASIC, yes. And also others like Coxiella burnetii, which causes Q fever, Bartonella brucella. These need special tests or conditions.
Okay, so prior antibiotics or specific tricky bugs. Let's talk risk factors then. Who is most likely to get this? Can we list the key ones?
Sure. For easy recall, think. Number one, any pre-existing heart condition. That's huge.
Like valve disease, congenital problems.
Exactly. Prosthetic valves are a major risk. A previous episode of IE itself is a big risk factor, too.
Okay, makes sense.
Then number two, Intravenous drug use, very high risk.
Right.
Third, invasive procedures. That includes dental work, especially if it causes bleeding, but also other medical procedures.
Okay.
Also, having chronic intravascular catheters like long lines, being immunocompromised for any reason, and just general recreational drug misuse can be a factor too.
Got it. So how does it actually happen? The pathophysiology, what's going on inside the heart?
So basically, you get microbes, bacteria, or fungi sticking to a damaged surface inside the heart, usually a valve, sometimes a lining.
Okay.
And once they stick, they multiply and form these clumps called vegetations. It's a mix of the microbes, platelets, fibrin, inflammatory cells get involved too.
And these vegetations cause damage.
They do. They cause local damage, inflammation, and bits can break off, embolize, and travel through the bloodstream, causing problems elsewhere.
You mentioned damaged surfaces. Does the surface usually need to be damaged before the bugs arrive?
Generally, yes. The thinking is that often there's a prerequisite state called non-bacterial thrombotic endocarditis, or NBTE.
And BTE.
Yeah, so that's like a sterile little clot, just fibrin and platelets, that forms on a damaged area first. Then, if bacteria get into the blood, they can latch onto that sterile thrombus.
Interesting. And what causes that initial damage, or the NBTE?
Well, underlying valve disease, obviously, but also things like high-pressure jets of blood across abnormal valves. There's this thing called the Venturi effect.
Fluid dynamics.
Sort of, yeah, where blood speeds up through a narrowed area, the pressure drops just beyond it, and that turbulence and low pressure seems to encourage these sterile thrombi to form.
Okay. And conditions like chronic kidney disease, cancer, SLE, malnutrition, they can predispose to NBTE too.
Exactly. Those systemic conditions can make the endothelium, the heart lining, more sticky, you could say, more prone to forming these initial sterile vegetations.
And you mentioned acute versus subacute earlier.
Right. Acute IE is often more aggressive, maybe Staph aureus directly invading tissue. Subacute is typically slower, like Strep viridans setting up shop on pre-existing damage, involving immune responses too.
Okay, that clarifies things. Which valves are most commonly hit? Is there an order?
Yes, there generally is. The mitral valve is most common,
Mitral first.
then the aortic valve. Then, seeing both mitral and aortic involved together, after that comes the tricuspid valve.
The IVDU one.
Often, yes. And finally, the pulmonary valve is the least common. Quite rare, actually.
So mitral, aortic, both tricuspid, pulmonary. Is there a mnemonic for that?
You could use MATTP, M-A-T-T-T. Most affected, pretty rare.
MATTP.
Or-
Okay, I like that. We've touched on specific organisms, but let's revisit quickly. Staph aureus again?
Yeah, worth repeating. Staph aureus. Think prosthetic valves, think IV drug use, think higher mortality. It's aggressive.
Okay. Coagnicative staph.
More subacute picture, also associated with prosthetic valves quite often.
Pseudomonas.
Pseudomonas aeruginosa often means trouble. Frequently requires surgery to clear the infection.
Right. HAC key group again?
HAC, typically subacute, maybe around 5% of cases overall. Slow growers.
And fungi. Enterococci.
Yep, they can cause IE too. Fungal IE is particularly serious, often needs surgery. Enterococci often seen in older patients or after GU procedures.
This really sounds like something that could be mistaken for other conditions. What's on the differential diagnosis list? What else could it be?
Oh, definitely. Within cardiac conditions, you've got to think about acute rheumatic fever, especially in younger people.
Okay.
Also the non-infective ones we mentioned. NBTE itself, Libman-Sachs in lupus, Murantic endocarditis with cancer.
Right.
And then there are non-cardiac things that can overlap. Systemic lupus itself can cause fever and murmurs. Cardiac tumors, like an atrial myxoma, can sometimes mimic symptoms.
Mm-hmm.
Lyme disease, antiphospholipid syndrome, even things like polymyalgia rheumatica or reactive arthritis can sometimes present with confusingly similar features initially.
And the revision notes pointed out some really tricky presentations where IE might not be the first thing you think of.
Absolutely. Like presenting as acute meningitis, but the CSF is sterile, no bacteria grown, that could be MLA.
Oh, yeah.
Or a stroke, especially from an embolus to the middle cerebral artery that carries a really high mortality, sadly.
Gosh.
Painless hematuria blood in the urine could be small kidney infarcts from emboli. Splenic infarcts causing abdominal pain. Sudden blindness from a retinal artery occlusion.
All from bits breaking off the heart valve vegetation.
Exactly. Even an MI, a heart attack if an embolus goes down a coronary artery. Pulmonary emboli if it's right-sided, i.e. kidney failure, AKI, musculoskeletal stuff that looks like arthritis.
And those classic name signs.
Right, the immune complex signs like Osler's nodes, Roth spots in the eyes, even palpitations if there's myocarditis or back pain from immune complex deposition, it can be incredibly varied.
It really highlights the need for suspicion. How common is this overall? What's the epidemiology like in the UK?
The incidence is estimated around 3 to 10 cases per 100,000 people per year here in the UK.
Okay, so not super common, but not vanishingly rare either.
Exactly. And it's definitely more common in older adults and, as we've said, people with those underlying heart conditions or risk factors.
And globally.
We're seeing trends towards older patients and more cases linked to healthcare interventions, devices, lines, procedures.
And that shift from strep to staph.
Yes, that's a key epidemiological shift. Staphylococci, often Staph aureus, have overtaken streptococci as the most frequent cause overall, particularly driven by healthcare-associated infections.
Tell me, are healthcare associated?
A significant chunk, maybe 25–30% of cases now.
Wow. Any gender difference? Age groups?
Tends to be a bit more common in men. And yeah, definitely seeing increasing incidences in people over 60. Often they have other issues too, like diabetes, cancer, maybe alcoholism.
Okay, so let's crystallize the clinical picture. What are the absolute key symptoms and signs that should scream, consider IE?
Okay, symptoms first. Fever is very common, obviously. Chills too. Poor appetite, weight loss, feeling generally unwell, fatigued, those constitutional symptoms.
Flu-like.
Yeah, very much so. Can also have more specific pain, back pain, chest pain, pleuritic sometimes, abdominal pain. And then the big cardiac ones, a new heart murmur, or a change in a pre-existing one, signs of heart failure developing, and signs of those emboli we talked about.
Okay, and on examination, the signs.
Well, the new murmur is key, often aortic or mitral regurgitation. Then look closely for the peripheral signs. Petechia, tiny red spots on the skin, in the eyes, conjunctivae, inside the mouth.
Okay.
Splinter hemorrhages under the fingernails. Osler's nodes, those are tender, raised lesions typically on fingers or toes. Roth spots, retinal hemorrhages seen on fundoscopy. Janeway lesions, these are non-tender, flat, reddish spots, usually on palms or soles. You might find arthritis, usually 1 or 2 joints, asymmetric. An enlarged spleen, especially in subacute cases, and maybe even signs of meningitis if there's CNS involvement.
So, quite a checklist. When does suspicion get high enough to really trigger the workup? What are the specific criteria for investigating?
Okay, key triggers would be a febrile illness, PLUS, one of the following, either a new regurgitant murmur or a known high-risk heart lesion, or someone with a predisposition like IVDU who also has bacteremia, heart failure, a conduction block on ECG, or evidence of embolism. That combination is a strong signal.
Okay, fever plus something specific.
Right. Also, think about it in someone with an at-risk lesion who has a more prolonged history, weeks of night sweats, weight loss, feeling generally rubbish.
The subacute picture.
Exactly. Also, any new unexplained embolic event like a stroke in a younger person without other risk factors, or persistently positive blood cultures where you can't find another source. And one more. A catheter-related bloodstream infection where the blood cultures stay positive even after you've taken the catheter out. That's suspicious for seeding onto a heart valve.
Okay, so if suspicion is high, what tests do we order? What are the crucial investigations?
Blood cultures, absolutely number one. Need multiple sets from different sites, ideally before starting antibiotics if possible. That's critical to identify the bug.
Okay, blood cultures first. Then?
Basic bloods. Full blood count might see anemia, high white cells. Inflammatory markers ESR and CRP will usually be elevated.
Makes sense.
Imaging. Echocardiogram is essential. Start with a transthoracic echo, TTE. It's non-invasive.
The jelly on the chest one.
That's the one. But if that's negative or unclear, or if you have high suspicion, especially with prosthetic valves, you often need a transesophageal echo, TE.
The probe down the throat.
Yeah. Gives much better pictures of the valves, especially looking for abscesses or prosthetic valve problems. Chest x-ray is useful too, mainly looking for heart failure signs.
Any other imaging? Newer stuff?
Sometimes. In complex cases, things like cardiac CT, maybe PT scans, or labeled white cell scans might be used, but echo is the mainstay.
Bedside tests.
ECG is important. Looking for new conduction problems like heart block or changes suggesting ischemia. Urinalysis, too, check for blood or protein, which could indicate kidney involvement, those immune complex deposits.
What about specific blood tests for the tricky bugs?
Yes, if cultures are negative, you'd specifically request serology for things like Coxiella, Bartonella, Maybe Brucella if there's an exposure history.
Yeah.
Don't bother with Candida antibody tests, though. They're generally not helpful for IE.
And if the patient needs surgery and a valve is removed?
Absolutely. Send that excised valve tissue for microbiology, culture, and histology. And if the cultures were negative beforehand, ask for PCR testing or gene sequencing on the valve tissue itself. Might get an answer that way.
Okay. So we've got symptoms, signs, test results. How do we formally make the diagnosis? The Duke criteria.
Yes, the modified Duke criteria are what we use. They combine clinical, microbiological, and echocardiographic findings. It's based on major and minor criteria.
Right. What are the major criteria?
There are two main types of major criteria. First, positive blood cultures. But it has to be typical, i.e., organisms grown from two separate cultures, or persistently positive cultures for less typical bugs.
Okay. Specific blood culture findings.
Second major criterion, evidence of endocardial involvement on echo. This means seeing a vegetation, an abscess, a new leak around a prosthetic valve, dehiscence, or a definite new valve regurgitation murmur.
So positive cultures or positive echo findings, those are the big ones.
Those are the majors. Then you have the minor criteria.
What do they include?
Minor criteria include things like having a predisposing heart condition or being an IV drug user, fever over 38 degrees Celsius, vascular phenomena like major emboli, Janeway lesions, conjunctival hemorrhages, immunological phenomena like Osler's nodes, Roth spots, glomerulonephritis, microbiological evidence that doesn't meet the major criteria like a single positive blood culture for a typical organism, or PCR evidence. And finally, echo findings that are suggestive of IE but don't quite meet the major definition.
So you need a combination of these.
Exactly. To make a definite diagnosis, you typically need either 2 major criteria or 1 major and 3 minor or 5 minor criteria.
Got it. And we mentioned blood culture negative IE again. Why does that happen and how common is it?
Right. As we said, often prior antibiotics or those fastidious organisms like HAC, Coxiella, Bartonella, fungi. It can account for a fair number of cases, maybe 5–10% or even more in some series. So you can't rely solely on positive cultures. You have to use the whole clinical picture and the Duke criteria.
Okay, makes sense. So let's say we've diagnosed IE. What's the management approach, particularly thinking UK practice?
Right. The core principles are prolonged intravenous antibiotics, tailored to the specific bug and its sensitivities. Potential surgery to repair or replace the damaged valve or remove infected material, and supportive care for symptoms and complications like heart failure. Prevention in high-risk people is also key, but maybe we touch on that separately.
Okay, so Vitamin antibiotics are the mainstay. How long?
Usually a long course, typically 4 to 6 weeks of IV therapy. It needs that long to penetrate the vegetations properly.
Wow, 6 weeks, 4. That's a long hospital stay, usually.
Often, yes, although sometimes outpatient IV therapy, opiate, can be arranged for stable patients later in the course. It's always guided by infectious disease specialists and microbiology.
And what about surgery? When is that needed?
Surgery is often required. Key indications include significant heart failure caused by the valve damage, persistent infection or sepsis despite appropriate antibiotics, evidence of abscess formation or fistula tracts around the valve.
Okay.
Also, if the valve is literally falling apart, perforation or dehiscence of a prosthetic valve, recurrent emboli despite antibiotics, pretty much any prosthetic valve endocarditis often needs surgery, and fungal, i.e. almost always require surgery plus antifungals.
So quite a few triggers for calling the surgeons.
Definitely. Early surgical consultation is recommended in many cases, especially with prosthetic valves, large vegetations, or complications developing. There's evidence that early surgery in some situations, like left-sided, i.e. with large vegetations and risk of emboli, might improve outcomes.
What about that prevention aspect? Antibiotic prophylaxis before dental procedures. That used to be common.
Yeah, the guidance on that has changed significantly. Current NICE guidelines in the UK do not recommend routine antibiotic prophylaxis for dental or other procedures just based on risk category anymore.
Oh, really? So no antibiotics before the dentist for someone with a valve replacement?
Not routinely, no. The focus now is much more on maintaining excellent oral hygiene generally and promptly treating any infections that do arise. The risks of routine antibiotics resistance, side effects were felt to outweigh the uncertain benefits for most.
So the emphasis is on good hygiene and treating infections if they happen.
Exactly. However, if someone at high risk is undergoing a procedure where infection is suspected or confirmed, then antibiotic coverage would be given as treatment, but not just as routine prevention for a clean procedure.
Okay, that's a really important clarification. So treatment is long 5E antibiotics, surgery for complications.
Yeah.
What's the prognosis generally like?
It really varies. Depends heavily on factors like the patient's age, their other health problems, whether it's a native valve or a prosthetic valve, the specific bug involved,
Right.
whether there are complications like heart failure or stroke, and how quickly treatment was started.
Can you give some rough cure rate rates?
Well, for native valve, i.e. caused by, say, strep viridans, cure rates can be quite high, maybe over 90% with appropriate treatment. For Staph aureus native valve, i.e. it's lower, maybe more like 60–70%. Fungal, i.e. has a much poorer prognosis.
And prosthetic valve, i.e.
Generally carries a worse prognosis than native valve, i.e. higher risk of complications, higher mortality.
What are the overall mortality rates like?
In-hospital mortality for IE can still be significant, unfortunately, maybe around 15–20% for native valve IE, and potentially higher, maybe 20–30% or more, for prosthetic valve IE, depending on the study and patient factors. Factors like older age, aortic valve involvement, heart failure, CNS complications, and infection with resistant organisms like MRSA or fungi predict worse outcomes.
So even with modern treatment, it remains a very serious condition.
Absolutely. Prompt diagnosis and treatment are crucial, but it's definitely not something to be taken lightly.
And finally, let's just list those potential complications again.
Yeah.
What can go wrong with IE?
A lot, unfortunately. The big categories are direct cardiac damage, embolic events, and metastatic infection or immune phenomena.
Okay, so cardiac damage.
Valve destruction leading to severe regurgitation and heart failure is probably the most common major complication. You can also get abscesses forming in the heart muscle or around the valve ring. Fistulas can form, pericarditis, arrhythmias, even heart block if the infection spreads to the conduction system.
Embolic events.
Bits of the vegetation breaking off and traveling in the blood. If it's left-sided, i.e., they can go anywhere, brain causing stroke, spleen, kidneys, limbs, coronary arteries causing MI. If it's right-sided, they go to the lungs causing pulmonary emboli or infarcts.
And metastatic infection or immune issues.
The emboli can seed infection elsewhere, causing abscesses in the brain or spleen, for example. You can get mycotic aneurysms, weakening of blood vessel walls due to infection, which can rupture, septic shock, obviously. And the immune system response can cause problems like glomerulonephritis in the kidneys or arthritis.
Wow. A truly systemic illness originating from the heart.
Precisely. It underlines why recognizing and treating it effectively is so important.
Okay, fantastic overview. So just to hammer home the absolute key takeaways for exam recall, i.e. infection of endocardium valves.
Yeah.
Staph aureus is now the most common cause overall. Remember the Strep Bovis linked to colorectal cancer. Big risk factors. 5E drug use, prosthetic valves, prior, i.e. classic signs. Think Osler's nodes, Roth spots, Janeway lesions, new murmur.
Yep.
Diagnosis relies heavily on the modified Duke criteria focusing on blood cultures and echo finding.
Crucial.
And management is prolonged 5E antibiotics, often 4 to 6 weeks, with a low threshold for considering surgery, especially for complications like heart failure, abscess, or prosthetic valve involvement. And remember, no routine antibiotic prophylaxis anymore for most procedures.
That sums up the core beautifully. Those are the absolute essentials to have locked down.
Excellent. Well, hopefully that deep dive helps solidify those key points for anyone preparing for exams or just wanting a refresher.
And for more detailed revision resources, practice questions, and help nailing the MSRA, definitely check out pastthemsra.com and also free MSRA.com. Loads of useful material there.